familiar on that.
Just so you know, I don't know how a lot of the apps work with iOS 7 yet. Apparently they just released the iOS 7 for iPad. My suggestion is to get into this semester before you fuss with it. If you haven't, that's fine, but I'm just not sure that all of the apps are up to date with the new system, because I know some of them are coming out, like Socrates saying they're coming out with 2.0. I imagine that's their response to them having to work with iOS 7. Because like on this one, she updated and then sufficient fits with the programming, so I'm not sure, but to keep your life simplistic, I follow the KISS principle, keep it simple, stupid, and don't update everything at this point. Now, those of you who have updated or updated your phones, that thing is a 9,000,000% battery drain for the cool features that it gives you. So there's a lot of things, if you don't know how to turn off, I would suggest you figure out how to get them turned off, just because it eats batteries. This one's down to 23% already, so. That's all I have to say about that.
What cool features? What cool features?
Everything.
Like it's a battery?
Yeah, it kills my battery.
All right, folks, talking about the new day. Injuries associated with it. Okay.
Yeah.
First, we'll start off with the overuse injuries. IT band friction syndrome. Last week we talked about it up in the hip and then this is in the knee. And it's referred to as reverse knee. It's where that IT band isn't tracking right over that lateral femoral condo. And that's just going to cause inflammation, pain when running or doing activity and whatnot. And this will get put up on Blackboard eventually. So what do you guys think could be some predisposing factors to ITB? Thinking about anatomy and what it does. What muscles could be tight that would cause this?
Tensor?
Yeah,
Tensor fascia.
Hamstring tightness too. What about biomechanically, like how they are performing? Think above and below the joint. Foot patterns. What? Yeah, okay. Any excessive pronation? So genivarum, you guys heard of genivarum, genivalgum? Okay, so genivarum is where you're knock knee and genivalgum is bow leg. So you have a varus, hence varus stress is going inward, valgus stress is going outward. So if you think valgus laterally, so it's going out laterally. That's the way I always remembered it. So excessive pronation and internal tibial rotation. Wait, I said those backwards, sorry. About genivarum, genivalgum. So treatment for this, modify activity. You can cut them if it's a cross-country runner, or you can cut them down off of running by limiting the impact on the ground. So you could do cross-training, swimming, elliptical, biking, and then improve hamstring, IT band flexibility, hip abductor strengthening. You can do deep tissue massage to try and loosen up the tensor fascia and IT band too, and also some modalities. Okay, popliteal tendinopathy. This will be just a little inflammation of that tendon. It goes in the back of the knee joint and it pretty much is responsible for unlocking the knee and also also contributes to a little bit of like the internal rotation. So they'll present this with you saying that they'll feel tight behind the knee, and they'll have pain in the posterior portion too. So sometimes this can get confused with a hamstring strain, because your hamstring tendon kind of runs in that same direction, and just be able to rule that out. Popliteal cyst, also known as a Baker's cyst, is located in the back of the knee on the outside, and this will happen when you're just getting increased irritation over the synovial, and that's just gonna create like excessive joint motion or irritation to it. So they'll be having swelling with it, and it's going to be also tender. It says that they can rupture, but you're not really going to see any ruptures until they're older, or like more older patients, and that can just be common symptoms like deep vein thrombosis. And then that's a picture of the Baker's cyst. Treatment, aspiration. Most likely they won't aspirate it because usually it's going to be associated with something else. So, like, say if it's associated with an injury and you're treating that injury, usually the symptoms will subside from it. So but if it does rupture, you just treat it symptomatically and then just do your normal ice compression, elevation, and rest. Osteoarthritis. I don't see a lot of this. Okay, so this is basically just degeneration of the joint. You guys have heard of this before. Related to old age, or if you have a traumatic knee injury and you continue to play on it even after you've had surgery. Like sometimes with meniscus degeneration or meniscal tears, whenever they have surgery, you can either go in and shave down the meniscus, or you can actually just repair the whole thing. But a lot of the times they're going to be able to shave it down at our point, or people around our age. So the doctor will warn them later on, hey, you may have some degeneration in the joint, just due to the fact because that meniscus is wearing down, there's no cushioning in between the femur and the tibia. That makes any sense. So those are 3 things that can happen, and like I said, you won't see this until older, unless there's really something wrong with someone disease. Okay, so there'll be pain on the weight-bearing leg. They'll report swelling up, maybe after activity. There'll be some stiffness in it, and walking or catching. Just some example of like see how right here how the femur is resting on that tibia plateau. Like right here it's normal.